All right, everyone. So, all of you who are new here, myself, Dr. Simran Kaur, I'm a radiology resident and an ECFMG certified physician. So, I've been mentoring students for USMLE through all these 3 years, and now, I'm here to, just discuss the high yield concepts for NEET PG that is just around the corner. And I've, tried my level best to include the images and the high yield concepts in this lecture. So let us move ahead and discuss the images along with the clinically relevant points. So number one, as you can see this image here. So one by one we would be discussing it. So what do you think? Which test is being done here? Which image is this? Which procedure is being done here? Yes, Gurjeet. Exactly. Hi, Sai. Good evening. So the test that is being done here is the tuberculin skin test, okay, which is also known as the Montu test. Now, first of all, you are supposing you are able to answer this question, so you should know few more details about it also, okay? So, when you talk about this tuberculin skin testing, these are the most high yield things that you should know about it. So, number one, this is also known as a Montu test. Number two, in this test, what you are using. So you are using 0.1 ml of the purified protein derivative that contains the 5-TU, that is the tuberculosis unit, okay, which is injected intradermally. This is very important. I'm going to mark the things that are really important. So intradermal injection, okay, and what you are injecting 0.1 ml of a purified protein derivative. Now, what you're going to do is for Montu testing, you require the patient to come twice, okay? One on the day when you are injecting that, and then you're gonna call the patient after 48 to 72 hours. So this is a kind of drawback for this test. Now you're gonna call the patient again after 48 to 72 hours, and you look for the induration. That is the area that is hardened. Okay, when you palpate, you feel the hardening over that area. Okay, so induration would be checked, not the redness. So this is a very important point. Do not just measure the redness, you measure the induration, that is the hardened part, not the redness. All right. Then you wanna talk about the condition. Like supposing you have called the patient after 48 to 72 hours. Now, how much induration should be there in order to call that patient to be, positive for the tuberculin testing or positive for the Montu testing? Now, in US, the guidelines are quite different. In US, we say that a normal healthy individual, if the induration is more than or equal to 15 mm, then that is a positive Montu test or a positive tuberculin skin test. But in India, where already we have a huge load of Mycobacterium tuberculosis infection, so here the induration of more than or equal to 10 mm is being considered the positive test. All right. So supposing they give you the question that this test was done, 0.1 ml of something was being injected, and ultimately after 48 to 72 hours, you see that the induration was around 11 mm or 12 mm, right? So that would be a positive test. But what you have to be really careful about is when you talk about a patient who is immunosuppressed, or if the patient is having AIDS, okay, when you call a patient to have AIDS, can anyone answer this question? When do you call a patient to have AIDS? Yes. See, HIV and AIDS are different. AIDS is when the CD4 count is less than 200, or if the patient develops AIDS defining lesions, if the patient is developing AIDS defining conditions. Okay, so AIDS patient is an HIV positive individual whose CD4 count is either less than 200 or the patient is developing the AIDS defining conditions. Now, supposing they give you a case of a AIDS patient and then they ask you that tuberculin skin testing was done. Tuberculin test was being done and the induration is 7 mm. Would you write it as a positive 1-2 test or a negative 1-2 test? AIDS patient and induration of 7 mm or 6 mm. Yes, exactly, Akash, you gave the right answer. So in AIDS patients or immunocompromised patients, or if they give you the patient of organ transplant. So post organ transplant, obviously, the patient is put on immunosuppressants in order to prevent the organ rejection. So these type of patients are immunosuppressed. So in these situations, the induration of more than or equal to 5 mm. Induration of more than or equal to 5 mm is being considered positive. Okay, so that would be a positive tuberculin skin testing. So these type of patients are an exception. So normally in a normal healthy individual, there is induration more than or equal to 10 mm, that is a positive test. But if the patient is of AIDS or organ transplant or immunosuppressed individual, then the induration of more than or equal to 5 mm would be called a positive test. Okay, then moving on to the next high yield concept. Before that, what is that? Which organism leads to tuberculosis? Which organism is responsible for causing tuberculosis? So that's a micro correlation. The organism is Mycobacterium tuberculosis. Mycobacterium tuberculosis. And how is it different from other organisms? This is an acid-fast organism. This is an acid-fast organism. Now, this is a very important point here. This has been asked several times. Why is it acid-fast? Like which property of mycobacteria helps it to be an acid-fast organism? Which property is responsible for the acid-fast characteristic of mycobacteria? Yes, exactly. The answer is mycolic acid. So increased mycolic acid in the cell wall, which mycolic acid is actually the cell wall component of mycobacteria. So mycolic acid is responsible for the acid-fast characteristic of this Mycobacterium tuberculosis. Okay. Then moving on to another point here. Supposing someone is having infection, but the patient is not showing signs and symptoms of the tuberculosis. What do you call it? Infection is there, but the signs and symptoms are not present. You would call it latent TB. You will be calling it latent TB. All right. And what are the first line drugs for TB? HRZE. Remember, streptomycin is not the first line drug for TB. HRZE, that is isoniazid, then rifampicin, then pyrazinamide, and ethambutol. These are the first line drugs for TB. Quickly, I'll discuss the side effect of few of these. When you talk about the isoniazid, isoniazid has to be given along with some supplementation. Which supplement would you like to add along with the isoniazid management? Which type of supplement would you give if you are prescribing isoniazid? Your answer to this question is yes, vitamin B6. Okay, which is also known as the pyridoxine. What is the reason? The reason is that isoniazid depletes the vitamin B6. All right. Another point is, why do you think isoniazid leads to pellagra-like symptoms? Pellagra-like symptoms. The answer here is same, that isoniazid depletes vitamin B6. It depletes vitamin B6. Okay, but what is the problem here? Pellagra is like due to the deficiency of niacin. Pellagra is due to the deficiency of niacin. Niacin is vitamin B3. Right? How is niacin formed? What is the precursor of niacin? Next question. The precursor of niacin is tryptophan. Okay, and tryptophan, it is having two fates. it could get converted into the niacin as well as into the serotonin. And vitamin B6 is a very important cofactor for the conversion of tryptophan into the niacin. Okay. Now imagine someone is taking isoniazid. You already know that isoniazid is going to deplete the vitamin B6. So what is going to happen? Niacin is not going to be formed. That is why you say that isoniazid could lead to pellagra-like symptoms. Alright. Then talking about the rifampicin, orangish discoloration of bodily fluids. So orangish discoloration of fluids, that is the urine will also yield a reddish orange color. And another point regarding rifampicin that you have to keep in mind, which is high yield, is rifampicin is an enzyme inducer. So if you have watched that lecture where I've discussed the enzyme inducers and the inhibitors, I've told you about rifampicin. So always remember the case scenario, which is very important. Combination of rifampicin with OCD. Rifampicin with OCD. So supposing some female is coming to you asking for the contraceptive advice, you should always take a history about tuberculosis. Why? Because rifampicin, if she is taking it, that is an enzyme inducer and it could induce the metabolism of OCPs, Okay, it will induce the metabolism of OCPs and there could be management of treatment failure with OCPs. That is, the patient will end up being pregnant. So OCP failure, remember this point. Then the last one, we talked about the pyrazinamide. Okay, pyrazinamide is also one of the first line drugs. Pyrazinamide increases the serum uric acid levels. The side effect, please keep in mind. So obviously, if something is increasing the serum uric acid levels, it is increasing the risk of gout. The risk of gout is increased. And in the previous lectures, I have also talked about the gout. That is the deposition of monosodium urate crystals in the joint. Okay, and the crystals are needle shaped and they are negatively birefringent. How would they appear under the parallel light? That is yellow color. And in the perpendicular light, that is blue. So these things should be on your tips. And moving on to the ethambutol. The side effect of ethambutol is red-green color blindness. Red-green color blindness. And it could also lead to optic neuritis. So all of these points regarding the first line drugs for tuberculosis, they are very important. How do isoniazid work? It inhibits the mycolic acid synthesis. And you already know that mycolic acid is a very essential component of the mycobacterial cell wall. Alright, so hence it leads to the inhibition of the bacterial cell wall. And when you talk about the ethambutol, the mechanism of action of ethambutol is also very important. It leads to inhibition of arabinosyl transferase. Okay, that is the enzyme that is being inhibited due to the ethambutol. Now moving on to the next high yield image. I'm going a bit fast today because I know you guys are just revising it. I don't want to be slow and waste your time. So moving on to the next slide here. So look here. What is this? What is shown in this picture? So let me zoom in. Can anyone tell me what is shown here? Yes, guys. What is being shown here? Look at the picture. Yes. Yes. Dr. Sanju, you gave the right answer. Akash, here we are talking about the basophilic stippling. Okay. Remember, here we are talking about the basophilic stippling. This is the picture that shows the basophilic stippling. Okay. Now coming on to the important points. What do you think basophilic stippling contains? Okay. What is it? So you should know that basophilic stippling contains the RNA and the ribosomal precipitates. So if they ask you what is contained, what are the contents of basophilic stippling, your answer should be that RNA and the ribosomal precipitates are there. And one more point that you should never miss is that it does not contain iron. No iron. This point please keep in mind. So the RBCs, they are containing this basophilic stippling, that is RNA and the ribosomal precipitates are present. Next high yield point regarding basophilic stippling, that is in which condition do you see basophilic stippling? Okay, so number 1, thalassemia. Number 2 is lead toxicity. Number 3 is sideroblastic anemia. Number 3 is sideroblastic anemia. These are the very important points that you have to keep in mind regarding the basophilic stippling. Now, moving on to the next high yield picture. Yes, so supposing a female comes to you with the complaints of dysphagia And when you see her, you examine her, you see the pallor, koilonychia, then you go for the iron studies and you find that there is iron deficiency anemia. Okay, so what do you think? What is this condition we are talking about? This is the endoscopic picture. So what is this? So which endoscope, number one, which endoscopic finding is given in this picture? Number two, what is the diagnosis? Looking at the history, which diagnosis will you make? Exactly. So Akash, Gurjeet and Sai, you gave the right answer. The answer to this question is Plummer-Vinson syndrome. Okay, Plummer-Vinson syndrome. So now let us discuss what are the important points regarding Plummer-Vinson syndrome. Okay, so number one, the triad you have to remember. So if any question mentions upper esophageal webs, dysplasia, and iron deficiency anemia, most likely in a female, okay, this triad, it points towards the Plummer-Vinson syndrome. And this is very, very important. Then what you are going to see here, in this picture, you are seeing the esophageal webs. Okay, ultimately these esophageal webs, they are narrowing down the lumen of esophagus, and since they are narrowing down the lumen of the esophagus, what happens is the patient is having problem in the swallowing, difficulty in swallowing, that is dysphagia. All right, so what are these esophageal webs? Basically these are the membranes of the normal esophageal tissue. So the membranes of the normal esophageal tissue that are protruding into the lumen of the esophagus, that are protruding into the lumen of the esophagus, these are the esophageal webs. Okay, now what is the problem here? Why we should take Plummer-Vinson syndrome very seriously? Can anyone tell me what is the complication that could occur due to Plummer-Vinson syndrome? Anyone? Exactly. Madhavan, you gave the right answer. The answer here is that it increases the risk of esophageal squamous cell carcinoma. So increased risk of esophageal squamous cell carcinoma. Squamous cell carcinoma. Guys, when you talk about the esophageal cancer, this is a cancer with a very poor prognosis. Okay. Now you can read about esophageal carcinoma from first aid. They have very nicely given the differences. So either it can be adenocarcinoma or it can be squamous cell carcinoma. So the risk factors for adenocarcinoma and the squamous cell carcinoma, they are very, very high. So you have to differentiate on the basis of the risk factors. Okay, that is really important. And which one is more common throughout the world, the variety. Now, moving on to the next high yield picture. Before that, a point here. Just a second. In case of iron deficiency anemia, what did I teach you? In case of iron deficiency anemia, what did I teach you? So first of all, guys, there is anemia. So hemoglobin will be reduced. Supposing you are being asked this as a narrow question, so hemoglobin levels are reduced. Second thing, this is iron deficiency anemia. So what will happen to the serum iron levels here? What will happen to the serum iron levels? The answer to this question is serum iron levels are decreased, reduced here. That is why we are calling it iron deficiency anemia. Third point, when you talk about iron deficiency anemia, what type of anemia is it? Microcytic, macrocytic, or normocytic? What type of anemia is iron deficiency anemia? Is it microcytic, macrocytic, or normocytic? The answer to this question is microcytic. Microcytic anemia. So if it is microcytic anemia, what will happen to MCV? Would it increase, decrease, or normal? Or would it remain normal? What happens to MCV in case of microcytic anemias? Your answer to this question is it is going to be less than 80. It is going to be reduced. Since I told you that anemias are most likely being diagnosed with, they are being differentiated on the basis of MCV. MCV less than 80 femtoliter, MCV normal. Normal MCV is 80 to 100. And third situation is that MCV is more than 100. Okay, so MCV less than 80 is microcytic. Microcytic. MCV 80 to 100, that is normocytic. Normocytic. And MCV more than 100 is macrocytic. Macrocytic. The next point, very important marker for iron deficiency anemia is serum ferritin levels. So guys, what happens to serum ferritin levels in case of iron deficiency anemia? serum ferritin levels? The answer to this question is that serum ferritin levels are decreased. Time and again it has been asked about serum ferritin. Okay, because this is a very important, crucial marker that differentiates the iron deficiency anemia from anemia of chronic disease. I have discussed this in the previous lectures, which are available on YouTube. So please go through them. You should know how to differentiate iron deficiency anemia from the anemia of chronic disease. Anemia of chronic disease. Because in anemia of chronic disease, what happens to serum ferritin? It is increased. Serum ferritin is increased in case of anemia of chronic disease because anemia of chronic disease occurs in chronic inflammatory or infectious conditions, and ferritin is a positive acute phase reactant, so ferritin levels are going to be increased in anemia of chronic disease. But iron deficiency anemia, ferritin levels are reduced because ferritin is the storage form of iron, and already we are talking about iron deficiency anemia, so the stored reserves are also gone. All right. So moving on to my next picture. So look at these two pictures. What is A and what is B? What is shown in A and what is shown in B? So one by one, what is A? What is A? Yes, Sai, you gave the right answer. This is oral hairy leukoplakia. Oral hairy leukoplakia. So what is B? What is B? Yes, Gurjeet, Akash, Madhavan, what is B? B is oral thrush. Oral thrush, which is also known as mucocutaneous candidiasis, okay? Oral candidiasis. So, till this point, we are very clear that number one is oral hairy leukoplakia and second one is oral thrush. Now, coming on to the high yield point here. How to differentiate between these two? Both of them are appearing as white plaque or white membrane on the tongue. Why are they differential diagnosis of each other? Because both of these, they are appearing as white plaque or white membrane on the tongue. White membrane on the tongue, right? So let us differentiate between these two. So this is a very high yield table. So remember this. When you talk about the oral hairy leukoplakia, number one, you should know that this is associated with EBV. EBV is Epstein-Barr virus. Okay, so when you talk about EBV, EBV stands for Epstein-Barr virus. Epstein-Barr virus. Okay, so there's a point here from immuno. Which receptor is being used by EBV? Which receptor is being used by EBV? Anyone? The answer to this question is CD21. Okay, so highlight this CD21. This is the receptor being used by EBV. All right. Now, another point. When you differentiate, oral hairy leukoplakia is associated with the EBV, whereas the oral thrush is associated with Candida albicans. Candida albicans, which is a fungus. Okay, EBV is a virus. Now, oral hairy leukoplakia presents as a painless, irregularly shaped white plaque, which is giving a hairy appearance. Now, what is the very high yield point regarding it? Most commonly, it is present on the lateral surface of the tongue. So, if you can see this picture one also, they have shown this white plaque or white membrane, which is present on the lateral side of the tongue. All right. So, the most common location of oral hairy leukoplakia is the lateral side of the tongue. When you talk about the oral thrush is appearing as a white plaque on a red base. Okay, white plaque on a red base, and it could occur anywhere, most commonly on the dorsum of the tongue. If you can see this picture, so they have shown this oral thrush on the dorsum of the tongue. Next high yield point, that is, you cannot scrape off the leukoplakia. You cannot scrape off the oral hairy leukoplakia, but if you try to scrape off the oral thrush, you can easily do so. So it can be scraped off. So imagine, guys, if you are scraping off this picture, the finding given in the picture B, what you're going to see is a very red area, erythematous area beneath this white membrane. Okay, so if you try to just scrape it off, you will see the erythematous area, red area. Okay, so these are the very important differences. Moving on to the next high yield image. Before that, guys, what type of patient profile could be given to you if they have to talk about oral thrush or they have to talk about oral hairy leukoplakia. What type of patient profile? Exactly, Madhavan, you give the right answer. So what type of patient profile you are expecting in the question to be? The immunocompromised patient. Immunocompromised patient. Most likely the patient, either they would give you HIV positive individual or they could give you the patient having AIDS. So HIV positive individual or patient having AIDS. This is the most likely patient profile that could be mentioned in the question, because these type of patients, they develop these white membranes that are oral hairy leukoplakia or candidiasis. Now moving on to the image 5. Image 5. So what do you think? What is given in this picture? What is given in this picture? Yes. So this picture is important for every DAM exam, for the INICT, NEET PG, USMLE, okay? So what is this? Yes, sign, this is the correct answer. The picture shows the Kayser-Fleischer ring, okay? Do not directly call it Wilson. Here you are being asked about the finding. So here what you're seeing is a brownish ring, okay? Brownish ring, that is the Kayser-Fleischer ring. Now this is not the iron deposition sign, okay? This is the copper deposition. Okay, now let us discuss the high yield points regarding the Kayser-Fleischer ring. Kayser-Fleischer ring is seen in the patients who have Wilson disease. So before proceeding further, I would like to discuss the patient profile that could be given to you in the history in the question, okay? So supposing you get a patient who is depressed, and the patient is having Kayser-Fleischer ring, this type of picture could be given to you. The patient is having deranged LFTs, deranged liver function test, all right, and along with that the patient shows Parkinson-like features. Parkinson-like features. So this is a very important kind of history that could be given to you in the question, okay? So new onset to depression, along with that the finding in the eye, the image. Then when you see the LFTs, they are deranged and the patient shows Parkinson-like features, for example, tremors, bradykinesia, rigidity. These could be seen. This is the kind of history that you expect in a patient who is having Wilson disease. So let us discuss the high yield points about Wilson. Before that, Wilson is also known as the hepatolenticular degeneration. Wilson disease is also known as the hepatolenticular degeneration. Now I'll tell you why. Hepato is related to which organ? Hepato is related to liver. Lenticular is related to what? The lentiform nucleus. Where do you see it? The basal ganglia. Okay. So if we talk about the Wilson disease, everyone knows that there is copper deposition. Okay. But you should also know, okay, why do you particularly call it hepatolenticular? Because liver and brain, they're the most common sites where the copper deposition takes place. And in the brain, basal ganglia especially. Alright. Now let us discuss the high yield points regarding Wilson disease. So number one, the pattern of inheritance that is shown by Wilson disease is autosomal recessive. That means for any disease, who is following the autosomal recessive mode of inheritance, both the alleles should be mutated. Then only the disease would be able to express itself. All right. Then the problem in Wilson disease is that the copper is not getting transported properly. Okay. Copper excretion problem is there, and copper is accumulating in the body. Body. Now let us discuss why this happens. So there is a mutation in the ATP7B gene, which is present on the chromosome 13. That is actually coding for the copper transporting ATPase. If there is a mutation in the ATP7B, ultimately, normally what happens is copper binds to apoceruloplasmin. And after binding to the apoceruloplasmin, Okay, there is conversion of this apoceruloplasmin to ceruloplasmin. So if copper is not binding to apoceruloplasmin, ceruloplasmin won't be formed. So one thing becomes very clear here, that what happens to the serum ceruloplasmin levels in Wilson? What happens to serum ceruloplasmin levels in case of Wilson? So your answer to this question is they are decreased. Okay, at this point you can say that the serum ceruloplasmin levels are decreased. Second thing, ceruloplasmin is a copper transporter. So if ceruloplasmin is not there, okay, copper won't be in the bound form. No one is transporting copper from the liver. So what happens is no binding of the free copper. So free copper levels would be more, and hence less transport from the liver. Okay, and hence the less transport from the liver to the bile. All right. So remember this, from the hepatocytes to the bile, the copper transport is inhibited. So ultimately, what happens to the free copper levels? They are high. So second point, since we talked that the serum ceruloplasmin levels, they are low in case of Wilson. Similarly, I can ask you what happens to the free copper levels in case of Wilson. Your answer here is free copper levels are increased. Okay. Serum ceruloplasmin levels are decreased. We have discussed this already. And ultimately, if free copper levels are greatly increased in the body, they will start to accumulate in different organs. They will start accumulating in different organs. So these are the different organs where the copper could accumulate. Number one, liver most commonly. Then I talked about the brain. These are the two most common locations where copper accumulates. Then the third, cornea, and then kidneys. Okay, this is not a number, just remember two most common locations. Number one is liver, number two is the basal ganglia and the brain. So in the liver, the patient could have hepatosplenomegaly. Okay, along with the liver, there could also be splenomegaly. Okay, why? Because the copper starts to accumulate in the liver as well as the copper accumulates in the spleen, so the size is increased. Then the patient could have jaundice, and the patient could also have ascites. Okay, when you talk about the copper accumulation in the basal ganglia and the brain, the patient will start to have Parkinson-like features. And a very, very high yield point here, so you can highlight it here, the wing beating tremors. Okay, wing beating tremors are low frequency, high amplitude tremors that are being seen in case of Wilson disease. So they are the high amplitude tremors. Keep this point in mind. Then talking about the cornea, I've already shown you the picture. So those are the Kessler rings. What are those? Calcium accumulating in the decimate membrane of the cornea, which is the basement membrane of the corneal endothelium. Okay, if this copper is accumulating there, then it would show this Kessler ring, which is a brownish ring. All right, and the renal, it will lead to Fanconi syndrome. So guys, what is this Fanconi syndrome? What is this Fanconi syndrome? Whenever you have to talk about Fanconi syndrome, remember, you should always write it as PCT failure. PCT failure. PCT failure means that the PCT, whatever function proximal convoluted tubule was doing normally, that is gone. Okay, normally PCT is responsible for reabsorption of maximum substances. So, a reabsorption of majority of substances. Majority of substances. Now, if PCT fails, obviously the things that were getting reabsorbed will now get excreted via urine. Okay, this is the reason why sodium, water, glucose, amino acids, bicarb, okay, all these things are coming out via urine. All these things are coming out via urine, since PCT is not able to reabsorb all of them. So this is what happens in Fanconi syndrome. So keep this point in mind. Okay. Then moving on to the next high yield image. So if you can see here, what is this picture showing? What is shown in this picture? Anyone? So it is written in front of you. Yes, so the picture shows here the circle of Willis. Okay, so here we are talking about the circle of Willis. So this is also very high yield. So let us talk about the important points here. Okay, what is circle of Willis and what is the clinical significance? First of all, if you can see, there are a lot of blood vessels that are joined together. Okay, so circle of Willis is a anastomosis. So what type of anastomosis? Anastomosis is a connection between the blood vessels. So formed by an anastomosis between the branches of dash and dash. So what are those arteries? Your answer is internal carotid artery, okay, and the vertebral arteries. So the branches of internal carotid artery and the vertebral artery, they are, they are anastomosing with each other, where around the optic chiasma and the pituitary stalk. And ultimately, this anastomostic network that is being formed, that is known as the circle of Willis. Okay. Now, why do we have this anastomosis? Why the branches are combined together? What is the reason? Can anyone tell? Why do we have the circle of Willis? What is the need for these branches to be anastomosing with each other? Why are these connected with each other? Yes, sign to avoid ischemia. So number one, circle of Willis ensures that the blood supply to the cerebellar hemispheres is equal. Okay. Second thing is that supposing there occurs any obstruction in one of the branch. Okay. So what could happen? If this anastomostic network is not there, that particular area of the brain won't be getting enough blood supply. So there could be ischemia and ultimately there could be brain damage. But this prevents the brain damage due to the ischemia, okay? Because there is a network of blood vessels that ensures that the blood is properly going, all right? Now talking about the clinically relevant point here. Okay, so this is another picture that shows you circle of Willis, all right? And there are different branches here. The clinically important point here is that there is an aneurysm known as a berry aneurysm. Okay, you might be knowing about it, and this is occurring very commonly. So the kind of patient that you could be given in the question is a hypertensive patient who has been a chronic smoker. So a hypertensive patient who has been a chronic smoker, okay, he developed an aneurysm which ultimately ruptured because the blood pressure was very high. So the aneurysm ruptured and ultimately there was leakage of blood over there. Okay. So keep this point in mind that there is something known as berry aneurysm, which are also known as the saccular aneurysms. Most commonly, they are occurring at the junction of anterior cerebral artery and anterior communicating artery. Okay, where they are present in the circle of Willis. All right. If you can look at this picture, they have shown this berry aneurysm, the cerebral aneurysm. Right. Now, very very high yield point, so you should mark it. That if there is rupture of the berry aneurysm, this rupture of berry aneurysm is a very important cause of atraumatic subarachnoid hemorrhage. Okay, so remember this atraumatic. Without the history of a particular trauma, if the patient is landing in the ER with subarachnoid hemorrhage, then most likely they are talking about the rupture of a berry aneurysm. All right, so this is a very important point. Hypertensive patient who is also a chronic smoker. Now moving on to the next yield image. Yes, so identify the lesion given in the image. What is the lesion given in this image? What is the lesion given in the image? Yes, Akash. What is this lesion? Yes, exactly. So what is this? This is a subdural hematoma. Okay, subdural hematoma. Guys, please, these brain hemorrhages, they are very, very high yield. So look at the CT pictures and you should know the characteristic finding in each type of hemorrhage. So this is the subdural hematoma. Okay, now let us discuss the high yield points. So what you should know in the brain hemorrhages is number one, the name, then the appearance on the CT, then number three, whose rupture, the blood vessel involved, whose rupture leads to this kind of hemorrhage. So when you talk about the subdural hematoma, number one, there is bleeding into the subdural space. Okay, there is bleeding into the subdural space. Second thing is that what is the subdural space we are talking about? Yes, subdural space. Subdural means beneath the dura mater. Okay, so beneath the dura mater, that is between the arachnoid matter and the dura mater, we have a space known as the subdural space. Here in this space there is collection of blood in case of subdural hematoma. And this subdural hematoma, it leads to, it is due to the rupture of bridging veins. So this is very high yield point, so mark it. Time and again it has been tested that the rupture of dash leads to subdural hematoma, rupture of dash leads to epidural hemorrhage. Okay, so this point is very, very important. So bridging vein rupture equal to subdural hematoma. Now what are these bridging veins that we are talking about? So bridging veins are connecting the superficial cerebral veins. They're connecting the superficial cerebral veins to the meningeal veins and the dural venous sinuses. Okay, so the connection between the superficial cerebral veins and the meningeal veins and the dural venous sinuses is by the bridging veins. Now, what could be the reasons for subdural hematoma to occur? Remember, subdural hematoma could either occur due to the head injury, or it could be a result due to the shaken baby syndrome. If the baby is being shaken very violently, okay, there could be injury. And then the cerebral atrophy, for example, a patient is elderly, age-related atrophy is there of the brain. Then the patient who is chronic alcoholic. So in chronic alcoholics, it has been seen that there is cerebral atrophy. Okay, all these regions, all these etiological reasons would lead to stretching, more stretching of the bridging veins. And if there is excessive stretching of these bridging veins, they will wear off. Okay, ultimately there will be rupture of these bridging veins and there will be subdural hematoma, that is collection of blood in the subdural space. Now, coming on to the picture here. So what you can see from this picture is that the shape, this is a crescent shaped hemorrhage. Okay, so remember if the question mentions crescent shaped hemorrhage, talking about the next high yield point, subdural hematoma, can it cross suture lines? Your answer is yes. Okay, it can cross the suture lines. But subdural hematoma, can it cross the midline? Your answer is no. It cannot cross the midline. So these points are very, very high yield, guys. Please make a note of it. They have been asked several times. Can it cross the midline? Subdural hematoma cannot. Okay, so what is the reason why it cannot cross the midline? What's the reason for that? The reason is that the subdural space is being bounded by the structure known as falx cerebri. So if they ask you, okay, what is limiting, what is stopping the subdural hematoma to cross the midline, your answer is going to be falx cerebri. Okay, so this is a very high yield point here. Moving on to the investigation of choice. So supposing someone is having this subdural hematoma, so which investigation would you like to do? So what is the investigation of choice in such case? So the answer to this question is CT. Okay, the CT is the investigation of choice in this condition. So there are three types of subdural hematoma depending on the time of onset: acute, subacute, and the chronic. Okay, so in case of acute subdural hematoma, the CT will show a hyperdense lesion. Hyperdense lesion, just like I showed you here, a hyperdense lesion. In case of subacute, subdural hematoma, the CT will show you the isodense lesion. Isodense means it would be as the same brightness as the brain parenchyma. So if the lesion is showing the same brightness as the brain parenchyma, obviously it becomes very difficult for us to identify the subacute subdural hematoma by doing a CT scan. So in this situation, what we would be doing is the MRI. Okay, so if they ask you in which condition MRI would be the preferred modality of choice, in case of subdural hematoma, your answer to this question is subacute. Why? Because in subacute subdural hematoma, the appearance on the CT is isodense. Okay, the lesion will appear isodense, so it is very difficult to identify it. Then chronic will appear hypodense. Then there is a situation in which there will be acute on chronic. Okay, acute on chronic bleed. So already there was some chronic subdural hematoma. Then again, one more region occurred and there was acute subdural hematoma. So this is acute and chronic variety. And what you see in case of CT scan is the mixed areas. the mixed areas of hyper as well as the hypodensity. All right. So this is what you wanna see on the CT scan in case of subdural hematoma. Talking about the next slide. So what is this? What is shown in this picture? Yes. Exactly. You guys gave the right answer. So this is what? Epidural hematoma. Okay. This is epidural hematoma. First of all, look here. It's kind of lemon shaped or lentiform shaped. Okay. So let's discuss about it. This is epidural hematoma, not subdural, epidural. Okay, sub means beneath or below the dura mater. Epi would be obviously above it. So epidural hematoma is the bleeding. Where will the bleeding take place? The bleeding will be between the dura mater and the roof of the skull. All right. And what you have to remember is the easy way to remember epidural hematoma and the blood vessel involved is remember emergency medicine. EM. So E for epidural hematoma and M for middle meningeal artery. So this is very high yield point. Mark it. Epidural hematoma occurs due to the rupture of middle meningeal artery. All right. The next question they could integrate it with the anatomy. That the middle meningeal artery is a branch of which artery? Your answer is maxillary artery. Okay. Middle meningeal artery is the branch of maxillary artery. This is a very high yield point. Keep this in mind. Then talking about the most common site. What is the most common site of epidural hematoma? Okay, remember Tyrion. So supposing there is a fracture in the skull at the Tyrion region. Tyrion is a region in the skull present on the lateral side. Okay, this is also very high yield point where different bones are joining together. So you should know which bones are joining together at the Tyrion. Number one is frontal, number two parietal, number three temporal, and number four is sphenoid. So frontal, temporal, then parietal, and the sphenoid bones, they are joining together on the lateral skull, and the point where they are joining together, this is known as the Tyrion. This is a very weak point, and what happens is that what is lying over this Tyrion? So the anterior division of the middle meningeal artery, it lies over this Tyrion. Okay, so whenever there is breakage in the Tyrion, whenever there is fracture over here, obviously the anterior division of the middle meningeal artery will get ruptured. And if this gets ruptured, what will happen? There will be blood in the epidural space leading to epidural hematoma. Okay, then another important point regarding this is the lucid interval. Although lucid interval is not specific for the epidural hematoma, but still more importantly, it is present in epidural hematoma. Lucid interval. What is the meaning of this statement? What is lucid interval? Anyone? What is lucid interval? Interval means a time period. Okay. So what happens is supposing someone is involved in a road traffic accident, there occurs some injury, the patient may lose consciousness for some time, and then these type of patients, they gain their consciousness after some time and they come to ER. Okay, this is the reason why if some patient is coming to the ER with the some kind of traumatic episode like road traffic accident, you always take a history of you know number one, the loss of consciousness. Right, so you always ask the patient, did you lose consciousness? And along with that, you also ask about the vomiting or bleeding. Sorry. Yeah. So this is lucid interval, and this is commonly seen in case of epidural hematoma. Now, just hold on for a second. Hi, so I guess you are able to hear me now. Yeah. So we were discussing about the epidural hematoma. So what would you see on a CT scan in case of epidural hematoma? So number one, this is a biconvex lesion. Okay, and it would appear hyperdense on CT, hyperdense. So if you can see the area of enhancement here, hyperdense. So this is going to show more brightness as compared to the rest of the normal brain parenchyma. That is why you call it hyperdense. So number one, biconvex lesion. Number two, the hyperdense lesion, and it does not cross the suture line. So if you have to compare epidural hematoma from the subdural hematoma, how would you like to do that? So let us write down those points. So SDH versus EDH. Subdural hematoma versus epidural hematoma. Okay. Number one, in subdural hematoma, there was rupture of dash. There was rupture of. Your answer is bridging veins. There was rupture of bridging veins. When you talk about the epidural hematoma, there was rupture of middle meningeal artery. There was rupture of middle meningeal artery, which is a branch of maxillary artery. And the second difference between subdural hematoma and epidural hematoma, this is based on the crossing of suture lines and crossing the midline. So subdural hematoma can cross suture lines, okay, but it cannot cross midline. But when you talk about the EDH, the epidural hematoma, cannot cross suture lines, but can cross midline. Okay, these are the points to remember in case of the epidural hematoma. Please know this. The epidural hematoma does not cross the suture lines and can cross the midline. Yes, so Madhavan, you are correct. Both of them show the lucid interval. Okay. Talking about the next image. Supposing you are given an image like this. What is this? Anyone? What abnormality is shown in this image? Yes, Akash, you gave the right answer. This image is showing the fibromuscular dysplasia, FMD. Okay, so this is very, very important. This is fibromuscular dysplasia. Now, before beginning with this fibromuscular dysplasia, I would also be talking about this fibrous dysplasia. Supposing the question tells you about fibrous dysplasia plus precocious puberty plus cafe au lait spots. If these points are given in the history, which diagnosis will you like to make? Fibrous dysplasia plus precocious puberty plus cafe au lait spots. What is the diagnosis? Exactly, Akash. The diagnosis is McCune-Albright syndrome. McCune-Albright syndrome. Okay, remember this. Fibrous dysplasia of the bone. Okay, that is different from fibromuscular dysplasia. Don't get confused. Fibrous dysplasia means the bone is getting replaced by the fibrous tissue. But in case of the fibromuscular dysplasia, supposing the kind of patient profile, most likely you would be given a female, okay, young or middle-aged female. So look at the important points regarding fibromuscular dysplasia. Fibromuscular dysplasia means that there is proliferation of the connective tissue as well as the muscle fibers. The connective tissue as well as the muscle fibers, they are getting proliferated in the walls of the arteries. Ultimately, if in the wall of the artery you see that the connective tissue is proliferating and the muscle fibers are getting proliferated, the wall of the artery will become very thick. So what will happen to the lumen? So supposing this is the artery. If there is proliferation of the connective tissue here, so the lumen of the artery will be narrowed down. Lumen is narrowed. All right. So if lumen is narrowed down, stenosis of the vessel, right? Stenosis means narrowing. Ultimately, there will be ischemia. That means the vessel would supply less amount of blood to the tissue. Okay. So supposing if this situation occurs in renal artery, if there is fibromuscular dysplasia involving the renal artery, all right, what will happen? Renal artery stenosis. All right, and renal artery stenosis is a very, very important cause of renovascular hypertension, right? A young patient coming to you with hypertension. This kind of history. Young patient coming to you with hypertension. You will always, exactly, you will always look for the renal artery stenosis. All right. So, if there is fibromuscular dysplasia in the renal artery, there will be renal artery stenosis. So, the blood delivery to the kidney will be reduced. Okay, this is a very important point. Blood delivery to the kidney will be reduced. If kidney is receiving less perfusion, if the perfusion to the kidney is reduced, this is one of the stimulus to activate the RAS. Okay, so what will happen here is RAS activation. RAS activation will take place. RAS is renin, aldosterone, angiotensin system. Okay, so renin, aldosterone, angiotensin system. This is the RAS. So what will happen? Ultimately, blood pressure will increase. Now, this is very high yield. Time and again, questions have been asked from this RAS. So if RAS is on your tips, you can solve this question. Okay. So why do you think under the influence of RAS there is increase in the blood pressure? Why? So remember, guys, when the blood pressure reduces, that is, if someone is having hypotension, okay. Second, when the circulatory volume is reduced, supposing someone is having hypovolemia due to any cause, maybe dehydration or maybe due to the excessive diarrhea or vomiting, or if there is beta 1 stimulation, okay, beta 1 receptors are getting stimulated in the kidney, or if there is decrease in the sodium delivery to the macula densa. So macula densa is a structure that judges the sodium delivery, okay, that how much sodium is there. Now, all of these are the stimuluses for the activation of RAS. These are the stimuluses for the release of dash. So your answer here is renin. Okay, all of these are the stimuluses for the release of renin. So the next question is renin is released from, yes Akash, that is the right answer. Renin is released from the JG cells, okay, juxtaglomerular cells in the kidney. So what is the function of renin? Once renin is released from the JG cells of the kidney, there is something known as angiotensinogen, which is there in the liver. From the liver, there is angiotensinogen that is being converted into angiotensin 1 under the influence of renin. So if they ask you in which reaction this renin is taking part in, you should know that renin is converting angiotensinogen into angiotensin 1. Now angiotensin 1 is getting converted into angiotensin 2 with the help of angiotensin converting enzyme, that is ACE. Okay, ACE. This is also very important point. And then the main player in the RAS is angiotensin 2. That is the main player in RAS. Okay, so what happens here is that when you talk about angiotensin 2 is a very important substance that increases the release of that increases the release of aldosterone from the zona glomerulosa. So if you talk about zona glomerulosa, what is that? So in the previous lectures also we had discussed that when you talk about the adrenal cortex is having 3 layers that you give GFR mnemonic. Okay, so G for zona glomerulosa, then F for zona fasciculata, and R for zona reticularis. Okay, what is being produced in zona glomerulosa? Your answer is aldosterone, which is a mineralocorticoid. What is being produced in zona fasciculata? Your answer is cortisol. And what is being produced in zona reticularis? Your answer is androgens. Now, who stimulates the zona glomerulosa to produce aldosterone? Your answer is angiotensin 2. Okay, and this is how you integrate it from RAS. That Angiotensin 2 is playing a very crucial role in stimulating the zona glomerulosa to release aldosterone. Okay, and what is the action of aldosterone? How will you learn the action of aldosterone? Sodium water in and potassium hydrogen out. Okay, so sodium water reabsorption and potassium hydrogen excretion takes place under the influence of aldosterone. And angiotensin 2 is a very potent systemic vasoconstrictor. It is a systemic vasoconstrictor. And ultimately, angiotensin 2 is also responsible for increasing the ADH secretion. Now, all these factors clubbed together will lead to what? They will increase the ECF volume. Along with that, they will also increase the blood pressure. Okay. So guys, if you see here, under the influence of RAS, what is happening? The blood pressure is increased. That is what we were discussing. How do you think RAS could increase the blood pressure? RAS activation. Okay. These are the factors that are responsible for increasing the blood pressure. Now, coming to the next point here. So look at this picture. Look at this picture. What is this picture showing? This picture is showing the snowflake cataract. Okay, this picture is showing the snowflake cataract. Where do you see it? In which condition do you see the snowflake cataract? Anyone? Snowflake cataract. Your answer is diabetes. Diabetes. Okay. So in diabetes mellitus, you can see the snowflake cataract. Moving on to the next picture. So guys, what are the two varieties of diabetes? Quickly tell me. There are two varieties, type 1. Majority, these are type 1 and type 2. Type 1 is autoimmune and type 2 is due to the insulin resistance. Type 2 is due to the insulin resistance. Alright, in both these conditions, what happens? In type 1, there is autoimmune destruction of the beta cells and ultimately insulin is not produced. So in type 1, there could be absolute insulin deficiency in long run. Insulin deficiency. But in case of the type 2, insulin is there but it is not able to act. Insulin resistance is there. Alright. Moving on to the next picture. What you are able to see here in this picture. So if you are given a picture like this, which condition will you mark? What is this? This is a rosette shaped cataract. There is a rosette shaped cataract. In which condition you see rosette shape? This is very high yield. It has been asked several times. Rosette shaped cataract. So rosette shaped cataract is seen in case of, yes, blunt trauma. Okay, blunt trauma to the eye. Keep this point in mind. Now look at the next image. If you can see this vertebra, there are dots. Okay, this is known as the polka dot sign. And polka dot sign is seen in case of vertebral hemangioma. Vertebral hemangioma. This is also very important. Polka dot sign in vertebral hemangioma. Moving on to the next picture. So this next picture is showing the onion peel appearance. Okay. And this onion peel appearance is seen in case of Ewing sarcoma. Ewing sarcoma. So guys, bone tumors, ovarian tumors, lung cancers, all the cancers, they are very, very high yield. So do not leave them. You can read them from first aid. They are very nicely given. Brain tumors based on the age group. Bone tumors based on the location. Okay. And ovarian tumors based on the, the epithelial tumors and all that. They are very, very important. Breast carcinoma, then all the cancers, you should not leave them. So onion peel appearance is seen in case of Ewing sarcoma. Then they can ask you which type of translocation is seen in Ewing's. Your answer is 1122. So T1122 translocation, history of a very young male, okay, a child, a boy would be given to you. The location is diaphysis. So if I ask you what is the location, what is the involvement in case of a giant cell tumor or osteoclastoma? Anyone? Osteoclastoma? Giant cell tumor. Your answer is epiphysis. Epiphyseal involvement. Similarly, We talk about Ewings. Ewings is diaphyseal. Diaphyseal. So know these 2 points. Alright. Now look at this picture. We can see the inferior poles of both the kidneys, they are joined together. Okay. This gives the appearance of a horseshoe. Okay. So this is a horseshoe kidney. Now what is the relevance of horseshoe kidney? Number one, this is the fusion of the lower poles of both the kidneys. Now, the next question that has been asked several times. During the fetal development, as the kidneys are moving from the pelvis up above, okay, these horseshoe kidneys, they are struck. A structure interrupts the ascent of these horseshoe kidneys. The answer here is inferior mesenteric artery. Okay, this is very high yield point, that inferior mesenteric artery, this is, interrupting the ascent of this horseshoe kidney. The next high yield point regarding horseshoe kidney, what are the associations of horseshoe kidney? So horseshoe kidney is associated with number one, the psychoureteral reflux. Okay. Number two, Turner syndrome. Number three, multicystic dysplastic kidney. And the last one is Wilms tumor. Okay. Which chromosomal involvement could be there in Wilms tumor? Which chromosomal involvement could be seen in Wilms tumor? Your answer is chromosome 11. Chromosome 11. So guys, if you know the name of the chromosomes with the associated conditions, it becomes very easy for you to identify from the question. Okay, for example, chromosome 4 is for achondroplasia, 11 is for Wilms tumor, 3 is for the VHL. So you should know these chromosomal associations. Try to chart chromosome 5. So all of these are very, very important. And another point regarding Wilms tumor, very important. 2 to 5-year-old child with the incidental finding of an abdominal mass, which is smooth. When you palpate it, it is smooth and not crossing the midline. Not crossing the midline. Alright. And 3 syndromic associations of Wilms tumor. Number 1, Dennis-Trash. Number 2, Beckwith-Wiedemann. Beckwith-Wiedemann syndrome. And the number 3 is Wager. Number 3 is Wager. Wilms tumor, aniridia, that is absence of iris, then genitourinary abnormalities and retardation, mental retardation. Okay. So these are the syndromic associations of Wilms tumor. And Wilms tumor is having a very important differential diagnosis, that is the neuroblastoma, in which there could also be an abdominal mass, but that abdominal mass is having irregular outlines and it crosses the midline. And the children less than 2 years are most commonly affected in that. Alright. So this is all about today's lecture. So tomorrow also I will be coming up with very high yield images. I hope you like this session. Please do write in comments and I'll see you guys tomorrow. Bye bye.